Yeah, so Gilead has about 1.5 million vials of remdesivir available. About 40% of that looks like it's going to be allocated to the U.S. That's not going to be nearly enough based on our calculations. With the updates recently from HHS around allocation, it looks like the initial remdesivir supply is going to cover only about half the patients who need it this month, with up to 300,000 patients eligible for the drug through the summer, not able to receive it until production begins to catch up to demand this fall. Now, I know Gilead is working really hard to try and address this. It's not a trivial drug to produce. It takes time. It takes specific raw materials. They've just signed several license agreements with generic manufacturers to help ramp up production. And we would expect more to become available globally in the coming months on a rolling basis.
Well, Brian, tell us your assessment of the strength of the data. You know, when Dr. Fauci has been talking about it more recently, he's been calling the benefit pretty modest, and he compared it to the earliest days of treating HIV, which is sort of an implication that, you know, it's just the first drug. It's not a be-all, end-all. How would you assess the data and your expectation that as this drug potentially gets combined with other drugs as it's being tested now, will it show more benefit with them?
Yeah, absolutely. So this gets to the question of not only how well does the drug actually work, but how should it be used? And as you know, we use some mixed data today. The strongest data was from a large study conducted at NIH, where remdesivir shortened the recovery time for severely affected patients from about 15 to 11 days and trended towards lowering the death rate modestly. We've also seen some less conclusive data for the drug coming out of China, where it did not reach its primary endpoint, but that did look like there were some positive signals there. Now, there are several studies that are going to be reading out over the next several weeks, and I think that's really going to help tell us exactly how well this drug works, where it might fit in, and who could benefit most from it. And that's going to be important to guide its usage, given the short supply. Now, in terms of your question about combinations, I think that's a really important point. So there's several different approaches that companies looking for corona treatments are taking. The first are the direct-acting antivirals. These are drugs that work by preventing the virus from replicating and spreading throughout the body and from infecting our cells, and that's the category that remdesivir falls into. Another main category are the anti-inflammatories or immune modulators, and the last category are the antibody treatments that are designed to mimic the body's own immunity, and those can be either derived from patients who've recovered from the virus or synthetically. There's definitely potential for different drugs in different categories to be used in combination. A lot more we still need to learn about how these drugs can best be used. Just as an example, it was thought that the antiviral drugs were only going to work well in the early stages of disease before the immune reaction starts to cause lung damage. But it turns out that that might be a misnomer. So still a lot left to learn, but combinations, including remdesivir, are certainly feasible.
Right. Well, Brian, we really appreciate the time you took with us tonight, and we look forward to continuing to follow your research on this as you've been really out in front of the pack in terms of modeling how much we'll be able to access this drug. Thanks for being with us.
Thanks for having me.
Scott.
All right, Meg, appreciate it very much. Thank you for that interview. Dr. Gottlieb, how concerned should we be about a possible remdesivir shortage?
Well, we're not going to have as much of the drug as we want. The NIH study looked at this drug in the setting of severe patients and showed a benefit in that setting. But ideally, you'd probably want to move this drug earlier. You'd want to use it more in the frontline setting. And that's how doctors are going to want to use it. So that when a patient who has coronavirus, who has comorbidities, has conditions that would predict that they might have a worse outcome, comes into the emergency room, this is a drug you might want to hang right in the emergency room and start the patient on it right away. We're not going to have enough supply heading into the fall to do that. So there's not going to be as much drug as we would want. I think later on in the fall, towards the end of the year, more supply is coming online, my understanding is, and I think supply is going to build all through the fall. Gilead's done a good job of changing the manufacturing process here, making it more efficient. It used to be a 9-month process. They've got it down to 6 months. They've reduced the number of steps. They've sourced more raw material for this. And so I think you're going to see supply ramp all through the summer into the fall. But ideally, this is a drug you might want to use on a bigger cohort of patients than what's going to be available.